Okay. Well, thank you all three, and I think, yes, Reverend Sum was here with us as well, for taking the discussion from yesterday and focusing us on recent events and real life emergencies where we've had to do the things talked about yesterday. I have thoughts and questions, but I'm going to open it up to the panel to ask the questions first. Eduardo.
One question is related to the time. You know, when you see the epidemiology curve from Zika or Ebola, as you present, in 10 months is finished, or at least 95% of the cases appear in these 10 months. That the time is very important. We cannot wait 6 months to prepare in some strategic plan and then start, because we are right now very late. And my opinion, usually when you know what virus is involved and what happened, and that happened right now in Latin America with the Zika, in different places, you know, in 10 months it's finished. And then it's moving to other places, but that places initially have only 10 months. That is, the global recommendation need to think in this outbreak or this epidemic is only 12 months in each places. And for that reason, my surprise is when you including one not action immediately. In my opinion, this is in the other way. We need to move in immediately to have a quickly answer from this.
I completely agree, and if I wasn't clear on that point, then I should have been more clear. You have to speak immediately, and there's only so much you can prepare in advance. The CIRC plan that I posted tells you from the very second the phone rings, my phone could ring right now with something, I can immediately go into talking about what we know, what we don't know, and what we're doing to find out, and that is critical. It's the point at which you get over that first 24 to 48 hours where you're just sharing the points that you know, where you have to start thinking, if this is going to last longer, if this is not something we've seen before, there are certain situations like floods or earthquakes, we have a general understanding because we do those frequently. If it's anything unique, you have to then at that point think strategically, because the danger is you just react and you keep reacting to the clamoring voices and don't think about who's really most at risk, who really needs to get the information from us, and what is it they need to do to protect their own health, because we can't do it for them. We have to work with them. Now, getting out to the communities is a tough challenge to do very quickly. I agree completely. It needs to be done. Maybe Julian, you can speak to that.
Can I make a second comment? This is very important because when you have a list of the recommendation, you lose the main idea. For instance, Zika right now is real mild disease. It's only a problem when you are pregnant. And of course, the small number of the Guillain-Barré. But the important is, the main objective is to try to look in what is the places you will have in the future Zika, because you have Aedes aegypti evaluation in each places. And that recommended this year, we need to reduce almost 0 to be pregnant. That is the goal. And that is important. If we make so many recommendations, we lose what is the more important part. In my opinion, we are doing so important list of the priorities, et cetera, and then we lose the key part. The key part is we need to reduce the pregnant woman during 1 year in the places we will have Zika.
Yeah, I agree. I agree with you. At community level, we have to do the same thing, informing what we know for the moment, and accepting that we don't know everything, and saying to the community, we are investigating and we will updating you. This is a process. We will updating you once we have more information in each in each in every time at every time and each moment. It is the same process at global level and at community level. But at community level, we have to be there and not designing everything in our office and bring the information. So we have to move people from the beginning, 24 hours or 2 days after the beginning of the outbreak, setting social mobilizer in the community, train social mobilizer in the community, and updating them so that they update also the community on what is going on and on real time.
If I could also just add one other piece, which is if your question was about avoiding pregnancy for 1 year, in some localities and countries, that's not an option for women, or it's very difficult even for them. You know, look, we've been trying to get people to use condoms for how many years, and we still don't know how to overcome that behavior. So some of these things, it can be a goal to delay or avoid pregnancy and to always use a condom when you're pregnant. But in practice, it's very difficult to do. And giving the women who need to know, their sexual partners who need to know, the information that they need is only part of it. Communication cannot alone solve this problem. There has to be vector control. There has to be, you know, providing of ways to protect yourself, or you can't do it. So it's very complex.
In Cabo Verde, for example, according to pregnant women, we communicators, we used the law, the right to the abortion, to inform women that you have this right. And I think Cabo Verde is one of the country with the best law in that matter, the matter of abortion. You are not asked why you want to have an abortion. If you are pregnant under 12 weeks, this is the only condition to have access to the abortion. So we prepare messages for health professionals to inform partners and their wives and pregnant women and women in childbearing age that they have to use this right that have been given by their states.
Yes.
Thank you all for your presentations. I have a question for Julian Anoko and Reverend Sumo. And I also want to congratulate you on the success of your work in response to the Ebola crisis and Zika. You both listed many, many important activities that were key to your success. And I want to know from your perspective, what are the most important activities to sustain going forward to prepare for the next event that we can't predict? And are you able to do that?
Answer first?
Go ahead.
Okay. Yes, it's very it's a very interesting question. I used to say that we should have been prepared yesterday and not tomorrow, yesterday. And I think now we are in a pre-epidemic period because we know that Ebola will come back. If it's not Ebola, it is another outbreak. And now at West African country, people, national countries are prepared. John Sumo can add on this issue. 2 weeks ago, we had a workshop on the communication, risk communication, and the preparation of on a new outbreak and the introduction of a vaccine, of Ebola vaccine, in the context of an outbreak. So this was organized by the regional office of UNICEF in West Africa in Dakar, and 5 countries was invited. Reverend John Sumo was there leading the Liberian delegation, and each country has now a draft strategy of how to be prepared. Strategies, action, what to do, gaps, a timeline. They have this strategy at preliminary stage. And I think Reverend John Sumo can give you more information. The countries are there. They are taking this into a great consideration. And at high level, political high level, presidents of their countries are involved, prime minister, government, private sector, and they were there together to prepare their country.
Reverend John, you want to add something?
Oh, yeah, thank you very much. I'd like to add to say that race communication remains key, especially when it comes to sustained community engagement. On the sustainability component, this is something that we are doing here in Liberia. We have engaged the media so that they get the right information. We developed a media toolkit listing all of the 14 priority diseases, identifying them and their key messages. And then we also had the joint evaluation team that was in Liberia assessing our preparedness, and then risk communication was actually one of those that we presented. And then those areas that we have some low gaps, we are working on that. So as part of the IHR regulation, we have a risk communication operational plan in place to make sure that sustained community engagement is also key, that we don't just leave everything as is in the face that we don't have any outbreak. So we are looking at all of those things. I think the question was quite important. How do we sustain it? And then what lesson in the midst of the low levels that we don't have any outbreak right now. We are not sitting now. We actually part of the integrated disease surveillance response strategy. Right now, we are actually in the various counties training the health promotion focus persons at the community level to just make sure that they are well prepared so that in the event, whether it's before, during, and after crisis, they are in a better position when it comes to emergency response. So I can say that risk communication remains key because it also deals with enrollment management. The enrollments that come about, how do we manage them? We had those experiences during the Ebola outbreak where people associated Ebola prevention with salt, bitter cola, kind of a fruit that is used here in West Africa. But all in all, we are saying that with risk communication operational plan that we have, we are moving forward, not waiting until there is an outbreak. So I just like to add this aspect there.
Thank you. Jenny?
My question is for Julien. First of all, thank you for an amazing presentation that was information rich and incredible. And at the very end, you mentioned being open-minded and innovative as keys to moving forward with effective communication. And so my question for you is, what do you see as some of the innovative, creative approaches that we might take next time?
Thank you very much. I will share just an example. When we was in Guinea, a pregnant woman died, infected by Ebola, and with the baby inside. She was 10 months pregnant. And according to the local culture, they have to open and take off the fetus and bury the fetus apart, the mother apart, because this is a very dangerous issue that have happened to the community. And if they don't do that, they will have something like 4 generations in the future of women in childbearing age dying when they are pregnant or when giving birth. So they wanted to carry the body and open the woman at home. And epidemiologists say, no way, we are going to bury the woman with the baby inside. So we had 26 villages protesting, willing to take the body, and they came to break the ETU managed by MSF to take the body and go. What we did in that moment was we called the main leaders, credible and influent. We said to them, as anthropologists, we know that our ancestor has a repair solution. In the case you have to break the prohibition, just go and find for the solution. They say the solution doesn't exist. I say, I know because I'm an anthropologist. I know that the solution exists. We can find together the solution and try to save the situation. So we went with the community. We look for the grandson of the man who have organized this ritual 80 years before. I don't remember. Anyway, and I called WHO and I said to WHO, we have to pay for this ritual, reparation ritual. WHO accepted. So we buy the goat, we buy white clothes, red clothes, black clothes, tissues, and we bought all rice, salt, palm, everything. So we organized together the ritual with the community, and we danced, we cried, we did everything together. And after that, we prayed our ancestor. We said that, please forgive us, protect our childborn daughter. We don't want them to die. We know that we did this bad, but we want you to protect us, and accept that we are wrong, but we are repairing the problem. And we were together, national authorities, partners, WHO, MSF, Red Cross. We went together to the village. We did the ritual, and we repaired the ritual, and we buried the woman with the baby inside.
Awesome. Thanks for sharing. Ed?
Well, thank you very much for the presentations. And with the chair's permission, I just wanted to respond with a comment because I've set up very nicely, considering the sessions about data and evidence, and much like the CDC's motto about prevent, detect, and respond, that's basically the FBI's mission statement as well. Right.
But they're going to be merged, so we have fewer regulations in the future.
But I really wanted to take this opportunity to comment, and only the fact that in the course of this morning, and especially yesterday, it seems that a lot of the communication burden has been foisted upon the health and scientific community and its engagement with the public. And just wanted to take the opportunity to say that the onus is on the government as well too, in that the U.S. had a very important learning experience when we had, on the heels of 9/11, the anthrax mailings. And with that, there was a very intentional attack utilizing biology. And in their immediate response, the FBI and the CDC response was very contentious. But as a result of that, though, we developed a very strong partnership, so that now today, if there is a suspicious or unusual event or outbreak, that we work together, law enforcement and public health, to rapidly determine, was this a naturally occurring event or was this intentional? And especially in both situations, it's critical to have the right data, the right evidence. And a good example is when we had the 2009 H1N1 incident. If you think about the particulars, it was an outbreak of influenza at an unusual time. It was not normal, different demographic that was being impacted, not the elderly, but it was the young adults, and unusual genetic elements when it was broken down. And at the time, the CDC, public health, was providing that information sharing to the FBI at a real-time basis, because in the event that if there was any other indications of potential criminal activity, that we would be ready to respond. And so we also have partnerships with Department of Homeland Security that has a national biothreat surveillance system in place, and that's BioWatch. And with the CDC too, the establishment of a laboratory response network system, so that when the FBI, we do actually collect our biological evidence, we have a laboratory system where it could be rapidly attributed to see whether or not, looking at the nature of the material. So this is all on the heels of 9/11 and the Amerithrax issue. But having all those painful lessons learned, the FBI has embarked in partnership with existing cooperative biological engagement programs with the Defense Department and State Department, under the auspices of those two programs, as well as the Global Health Security Agenda. We've been in Southeast Asia, we've been through parts of Africa, and established the same types of engagements. How do we build existing partnerships within law enforcement, within public health, and with agriculture? Because a lot of the focus has been on human health, but the animal and plant health is going to be incredibly relevant too. Looking at not only the potential zoonotic events, but also looking at the potential impact on the economy. If suddenly your borders have to be shut down to prevent the shipping, cross-border transport of livestock, that becomes a huge challenge too, as well as a potential vector transportation. And if you think about it that way too, then what does that do for a customs officer? What do they need to be on the lookout for? What do the communications plan look like for them? And also, especially for Southeast Asia and Africa, we also talked to government agencies that were transportation hubs. So it's not just the points of the actual outbreak, but now if you look at population movements, then you also need to look at other points of vulnerability as well too. And it's all under the lines of how do you not only look at protecting public health, but God forbid it, but if there ever wasn't an intentional incident, then suddenly you have to be able to look at, well, now you have to process potential crime scenes. It's not just an outbreak issue, it's how do you collect the evidence and properly handle that and look at the forensic evidence as well too. So this proactive engagement has been very powerful, has been I would classify as possible as an innovative approach in bringing the right stakeholders that typically may not be brought into the fold in the initial conversations. But for the benefit of the forum members, another aspect of communication and coordination that ought to be taken into account, that there have been some very painful lessons learned. We've taken those into account and established these very important partnerships that pre-9/11 wouldn't have been unheard of. And we've now been trying to take this internationally as well, and has been very another important part of scientific as well as I say health diplomacy, and has been very, very profound, very compelling, and very well received. And happy to provide more information on that for everybody. But thank you again, because you teed this up very nicely, and I'm very happy to provide more information for you as well too.
Thank you very much, and I'm glad we're working so well together. I did want to mention, so the tagline that I referred to in getting input from, a variety of communities was done not at government expense, but through the CDC Foundation, which was important because we don't spend time and money marketing the agency, but our reputation for telling the truth and saying what we know, and when we don't know things is critical, or people won't listen to us when we are trying to give that information. But when you talk about the global health security agenda, which we're also working with, and I know Rima mentioned it yesterday, it's critical that we continue to do work overseas and around the world, not just because it's the right thing to do, which it is, but we do have American interest there. Global travel is so important now to our economy, to our diplomacy, to everything. And our relationships are all better off when other countries are able to protect themselves, and when they have emergency operations centers, when they have the structures that Julian was talking about, it's better for us. And so when there's a question of should the US be working across the world, or is that WHO or someone else, I think very strongly that we are at risk if the world is at risk.
Thank you, Catherine. Yeah, I will just add that thank you, Ed, for the comments. And we've learned and we've come a long way since 9/11. And I would say not just our response was contentious, but our communication sucked. I mean, I was up here in DC, and basically the strategy was don't communicate, just don't say anything. So anyway, enough said. We've obviously, yeah. And that wasn't just from CDC. I think it was. So Jeff.
Thank you. Wanted to also ask any of the presenters if they have any reflections on their experience in the context of the international health regulations, in particular, how the expectations and the criteria set out in the IHR, how they related to your work, relevance, and whether or not you feel that you've achieved just a specific level of competence, or that's the right word, accomplishment in the context of the IHR and challenges going forward, or whether you think those recommendations are appropriate or need to be modified. Just any thoughts you might have about that.
Yeah.
May I come in?
Go ahead, Reverend.
Yes, from Liberia. This is Reverend Sumo. Regarding the international health regulation, Liberia there was a joint team of experts, external and internal evaluators that were in the country to assess our preparedness It has about 9 thematic areas, including biosafety and then, of course, risk communication, as I mentioned earlier. So the assessment was done to determine the strengths and weaknesses in our preparation, our emergency response. So that assessment was done and the findings submitted. So we are right now working, especially in the risk communication area, we are trying to work on those areas, the weaknesses that were identified so that we are in a better position in the event there is an emergency. So this is how much I can say about the international health regulation. Liberia has a document in place. It has about 9 thematic areas, including my area of risk communication. Thank you.
Yeah, I think that is the same thing in the case of Guinea, because before the outbreak, the Ebola outbreak, I think they were not really implementing the HR. And with the outbreak, they started reviewing, and now they have a document that they shared with us 3 weeks ago, Reverend Sumo. They shared with us, and where they were assessing the implementation of the HR at national level. But from the field, what we saw from the field was that the border was closed, and this was not really, this is not recommended by the HR. People close the borders, and without knowing that people living on the borders are relatives. You have a daughter here, the father is living in Liberia, the mother is in Sierra Leone. In the case of the triangle of Ebola, in Gekedu, Sierra Leone, and Liberia, called the Makona River Association. So people are crossing the border, but when the border are closed without respecting that the HR, and the outbreak will continue spreading among parents, among relatives, and this is what we saw in the field concretely. But now they are well prepared in implementing the HR in this moment.
Great, thanks very much. Those are great presentations. But Ed's comments, they're really good, just kind of triggered something in my mind that I'll throw out to the panel. So after kind of some failures in 9/11 and Katrina, we kind of embarked on a whole new strategy about leadership, sometimes termed meta leadership. But the whole idea was, how do you lead across organizations where you don't have authority? So now we have these really difficult, wicked, complex problems that, as Ed pointed out, really take in account a lot of agencies, organizations, et cetera. So Catherine, as the lead strategist for communications, how do you standardize the communication across 10 different organizations? Who does it? How's it worked out? And that could be done in Africa and Liberia or Guinea as well. So your comments, I'd be interested in.
Yeah, thank you. It's a huge challenge. And particularly, as I said early on in any outbreak, when you figure out who's going to be affected, you can bring people to the table. There's no way that you can bring everyone who, needs to be there immediately. So building in a regular process of touch base, I think, is very important. At CDC for Zika, for example, we had a summit with health communicators, local officials, epidemiologists, vector control experts, all of that in early March. We wanted to get well before mosquito season, so we gathered information, had this meeting, and then shared a whole bunch of resources. And one of the things someone said yesterday that, why do governments put stuff up on their website and think that's communication? I actually think the website is just a repository of information at this point. So when we put material on our website, it's just so everyone can see the same thing. It's just so, if you speak English and need information in that, government way, that you can go there and get that. But then we run into trouble when we expect other countries to also understand that. So we have to get into, translation and working with them. But the better part there is to talk with the people there and let them develop the messages and us take those in. But as you say, the timing often won't work well for that. So we create our own pieces, have as many touch bases and conversations as we can, and alter our messages as we get them back from the field. But to the core of your question, is a regular system in place that will go without a good, some good leaders in there? I don't think so. I think it's something that takes work and pushing with every outbreak from the communication side to be even in the room sometimes, certainly to be part of the decision-making process, and then to sort of early on connect with people at the states and the communities and other countries as well.
Let me ask other two speakers. You want to say something related to that, Julie?
Yes, what was succeeding, being effective, but not at the beginning of the outbreak, was advocate with national authority to settle a coordination communication at earlier as possible, because these are to allow people to work in an harmonized manner, develop messages together, the same message to be spread from the central to the district and to the village level. But this was not easy because in the case of Guinea, they haven't any experience in managing this type of big issue. So we provide a technical assistant, a lead communicator, risk communicator embedded inside the coordination to support daily decision taking, how to focus, to work on risk communication, how to define message, but also advocating from inside the coordination meeting. I think in the coordination in Guinea has a technical assistant during 2 years paid by partners. And in that case, he was by UNICEF and WHO and CDC has sent a lot of technical experts, data management, communicator who were also working inside, cleaning the data, providing data every day. And all of us, we work on supporting the national authorities. This is what we did in the field.
Okay, if I may just step in a little, when it comes to leadership, there are 2 documents I have with me. I have the National Health Promotion Policy in plain, then it has the other document that lists the Liberia Media Kit that details all of the 14 priority diseases, and then for the media, where they'll be able to use that on the radio, and then in their various news organizations or newspapers. At the leadership level, what we do is to develop the standard operating procedures to ensure that we are doing it together with our partners. We don't have one party doing something the other way around. So the national documents are actually serve as a guide to the implementation of social behavior change communication activities in the country. So that's why we crafted those documents, and they all have been validated along with our communication strategy as well. So those documents are the ones that have used at the national, throughout the country. So if anyone wanting to do any kind of a community engagement, you have to follow those guidelines that we have put in the health promotion policy and plan, and the same time our communication strategy and our risk communication operational plan as well. So on the line of how do we manage within different organizations or more, we have a standardized approach, especially one example is like the messaging component. When the messages are actually those that want to do community engagement in the various counties, the messages we carry there have to go through the National Message and Material Development Committee, and that is pre-tested and validated before they are used in the various communities. Other than that, we don't allow it there. So those are just some of the steps we take to make sure that our activities are actually coordinated. Thank you.
If I could just add one other thing to that point. I was in your office, Reverend Sumo, in the early days in summer of 2014, and you had a line of people out in the hallway waiting to talk to you, and your phone never stopped ringing. And the fact that you were able to pull together a standardized process and do all of what you did was really amazing in the midst of a crisis communication, because the demands on you just to go on TV and the radio were almost unmeetable. And the fact that you worked with the teams to get all of this standardized information, you're ready to go to the future, is really a wonderful thing. And I'm grateful to you for that.
Thank you very much. Appreciate it.
Great, thank you. We have a couple of minutes left. I was going to open it up to other participants in the room. Any questions? Yeah, Ed, go ahead, and then we'll take another one.
Sorry, I just wanted to respond to your question about the wicked problem, and it truly is a challenge. But through our international engagements, what we've done is by setting the challenge. We had representatives, for example, from ministries of science and technology, Ministry of Agriculture, national security, foreign affairs, and by showcasing, providing context, they all rapidly recognized that they are all stakeholders, whether they liked it or not, and that then aspects of the challenge fall within their mission space. So that actually helped facilitate a lot. Some good examples is that we talked about IHR, but then from a law enforcement perspective, the Biological Weapons Convention and UN Security Council Resolution 1540, which also deals with biology, comes into play too. And by posting that, our international partners realized that, well, if they meet those criteria, if they have their legislation on the books to satisfy that, the next question is, okay, now what? What do we do that? It becomes a matter of implementation. So the U.S., again, we help facilitate discussions because we don't have any problems airing our dirty laundry on some of our painful learning lessons, and just building off of that has facilitated quite a bit of discussion and overcoming that particular wicked problem.
Great, thanks.
Just very briefly, a comment and then a question for the panelists. Thank you very much. To the question of communications coordination, a classic dilemma, because every serious infectious disease or otherwise event is polycentric, so it always is a problem. When we think about the cutting edge internationally of how people are trying to really solve this problem, leadership, as mentioned, is central. But there's another thing, and that is, don't worry about the small stuff. So there is no hope and no expectation that we will all say the same thing all the time. Perspectives are different, understandings are different, constituencies are different. What's key, and this is where the leadership comes in, is knowing what's really important to coordinate and what isn't, all right? There is a dynamic reality that people actually want from their authorities, from their partners, from the response. And I think that's the sort of way we have to go, determining that, what's important and what isn't. The second thing, we've already touched on this, but I want to return before we close to the panelists. As much as we've been detailing success aspects of trying to right the Ebola ship, what we saw was one of the most tragic failures any of us have ever gone through in the first stages particularly. And those first stages of confusion and mismanagement, you've been describing all the ways in which you corrected that, but we can't forget that this occurred. And again, we've already touched on this, but I'd love some additional thoughts of the panelists of how we could avoid this again, what we can do different in terms of that rapid response in a different way. Thank you.
Thank you. Short answers, cognizant of time. Who wants to go?
I think that, and I mentioned the fact that we, as humans, use our assumptions. We use what we know from our experience. We use the past to go forward. My understanding of how we went wrong in the beginning was making assumptions that things would be easier, and that maybe groups that had not handled large outbreaks before could. It was in a newer area of West Africa. So there were cities and towns that were not experienced, and my guess is that just with every failure, we thought we knew more than we actually did know. I did want to say on the small stuff point, I think that there are incredible pressures, not just to get stuff out, but there's also either very loud or very influential voices that pull you away to the urgent realities, which turn out to be small stuff. And it's distracting, and I agree that you almost need to set aside part of your team to deal with those so that you can deal with the big and important urgent issues.
Yeah, from my side, I would just say that is important to support countries in being prepared before the outbreak. Because if we don't do that and we wait for the outbreak to happen, we will have a lot of problem as what we faced before. I think in this pre-epidemic period is the best moment to support those countries in building an effective communication, almost in a strategy document, but also maintaining the communication on all the structures as the mechanism, as a coordination, as a committee, watch villages committee at the local level, and see how we can continue providing some means to keep this mechanism working. This is the only comment I can bring to.
Okay, Reverend Sumo, last word.
Oh, thank you. From the onset, the focus actually was on the medical aspect as opposed to the preventive aspect. So what needs to be done differently subsequently is to provide the needed information that will empower or engage communities so that they take ownership, as my colleague earlier said. So if we inform community from the onset, I'm sure that will reduce the number of ETUs that were built during the course of the outbreak. So we do it differently by actually doing this bottom-up approach, and then we can later on work alongside with the medical services, engage the community, sustain that community engagement, so that they take ownership when it comes to the response.
Great, thank you. And please join me in thanking the panel for